grateful that we've been able to have Stephanie Stevens, the Texas Medicaid Director, join us as our final speaker. The Texas Medicaid program is one of the very largest in the country. It is a hugely important program. And Stephanie, I just asked her, I said, do you like your job? And she said, yes, but it's a tough one, and it is. And so I know you will give her all your attention. We're going to do something a little bit different. I'm going to have Stephanie come up. She's going to speak, and then Stephen Palmer, who is with the HMA Austin office, is going to actually come up on the stage as well, and he's got some questions, and the two of them are going to go back and forth. They know Texas Medicaid far better than I do, and so that'll be our format till 4 o'clock. And also, we have a reception, wine, beer, some hot hors d'oeuvres, etc., outside for you all. So please take a few minutes to stay afterwards and talk with everybody and enjoy your time. And thank you again so much for coming today.
Hi, everybody. I'm Stephanie Stevens, the State Medicaid Director. Thank you for having me here today to talk to you about Medicaid. I'm really glad to be here and glad to have had the chance to sit in on some of the panels. I always learn as much from you guys as I hope you will in this update. So I think you've covered a lot of ground today in this conference on how healthcare is evolving and working to improve quality and access. And really those same goals are present in the Medicaid program today. The Medicaid program is not a static program. We are continuously working to improve what we do. And some of that has been impacted or accelerated by the PHE. And in other cases, we have kind of long-term reform plans that are in place. And so I'll talk about both. Today, Texas Medicaid serves over 5.5 million people, and that is really impacted by the public health emergency. You may know that states are receiving enhanced federal funding to provide continuous Medicaid eligibility for people. And so one of the focus areas of the agency is really looking beyond the PHE. We don't know when the PHE is going to end. I could take a poll, and I'm sure you guys would all have different opinions about when that's going to be. But we know at some point it will end. And so the agency is focused on how do we unwind that continuous eligibility coverage that exists today. And our goal is really to maintain eligibility for those people who meet the requirements, as well as to reduce churn. And that's going to take a lot of people working with us. I think I've heard today healthcare is a team sport. I think this is an example of where we need folks on our team who are helping with that unwinding effort. And so we have created, in that vein, an ambassador program to work with stakeholders to help us support Medicaid members as we return to normal eligibility. And a key message at this point for Medicaid recipients is don't wait, respond and update. And what we mean is that one of the concerns through the PHE is just what level of information do we have on Medicaid recipients. And so we want to encourage people on Medicaid to update the information that we have to make sure it is accurate. We need accurate phone numbers, addresses, and we want to make sure that their accounts on our various online applications and we also have a mobile app are up to date. And then we also want people to respond. So during the public health emergency, Medicaid eligibility has been continued, but now as we start to move towards the unwinding, we really need people to respond to their request for information from the state. And we have a full ambassador toolkit that you can find on our website, and I'm happy to share information, but we really would welcome your participation in that program and in sharing these critical messages with our Medicaid members. Another area that we saw significantly impacted by the public health emergency was how Medicaid members access services, and we really saw greater use and acceptance of teleservices. When you look at prior to the public health emergency, Texas was already promoting teleservices. There had been a number of bills passed by the legislature, and we were seeing steady but slow growth in teleservices. The trajectory with the public health emergency really changed. Just as an example, in 2019, we had about 72,000 teleservice visits in Medicaid, which increased to over 1 million in 2021. So the use of teleservices really dramatically changed as a result of the PHE. And we are making permanent many of the changes that we allowed during the public health emergency. So we had some teleservices prior to the PHE that were in Medicaid policy, and we have made many of those permanent to continue to allow audiovisual and audio-only services in an array of areas like behavioral health, physician services, rural health clinics, therapies, service coordination. And again, this has really been driven in part by the flexibilities provided during the public health emergency, as well as House Bill 4 from the last legislative session. And our goal is really to use teleservices moving forward to help provide access across what you all know is a very large and diverse state. When we look beyond the PHE, we are continuing long-term reforms in certain areas of the Medicaid program. You may know that over the last year, we were very excited that the Centers for Medicare and Medicaid Services confirmed that we have an approved 1115 waiver, which is for healthcare transformation and quality improvement. This is a 10-year extension of our prior waiver. And the waiver really provides the framework for our Medicaid program and the authority for different aspects of the Medicaid program. And we use it to continue to expand managed care in Medicaid, to support a coordinated delivery system, to improve outcomes while containing cost growth, and to transition to quality-based payment systems. So one important part of the waiver and why we felt a really strong sense of urgency in getting the final approval was the ongoing PHE and the need to support our providers. So the waiver includes significant support for providers through directed payment programs and uncompensated care funding. And the providers that are included are primarily hospitals, behavioral health providers, rural health clinics, certain physician groups. And so we're very thankful that we now have that in place and are moving forward with operating under the 1115 waiver. There are also certain focus areas that we are trying to address access in, and we do that under the waiver. And I'll just provide a few examples. Of course, this isn't the comprehensive, but we are requesting CMS approval to increase postpartum coverage from 60 days to 6 months. We know that maternal health has been and will continue to be a major focus of the state. We are implementing coverage of certain behavioral health services in lieu of inpatient services through managed care. This is an option that states have to allow the managed care organizations to provide certain behavioral health services. And we are developing a pilot to provide additional long-term services and supports through the STAR Plus managed care program for people with disabilities. Another aspect of the 1115 waiver is the transition to quality-based payment systems across managed care and providers. Over the past 5 years, we have made progress in advancing value-based care and payment approaches. You may know that through our managed care contracts, we have targets for the amount of payments between the managed care organizations and the providers that are in alternative payment models, and those percentages increased over time. So from 2018 to 2021, the targets increased from 10 to 25% for at-risk APMs and 25 to 50% for total APMs. And what we've seen is the managed care organizations have generally met those targets, but there's still continued opportunity to advance alternative payment models. We've generally seen that many of the alternative payment models focus on primary care, hospital services. We see less in the area of long-term services and supports. We also see that the alternative payment models are often built on a fee-for-service model and will provide an incentive for a provider around quality, but we see less full at-risk payment models. And so moving forward, we will continue to promote the adoption of APMs, but based on the experience we've had over the last few years, as well as we have a value-based payment and quality improvement advisory committee, we are planning changes to provide a more comprehensive but still flexible framework for increasing the adoption of APMs that goes beyond just those targets. I think one of the things we've heard is the targets are helpful in moving the needle, but it's not the only thing that needs to happen. And so we're looking at how do we round out our approach to alternative payment models. And we think this will include recognizing partnerships that MCOs have on specific APM priorities and opportunities, incentivizing MCO achievement of quality and efficiency standards established by HHSC, and then encouraging MCOs to address a full set of activities important for successful APMs, such as provider engagement and data sharing. So what we're looking at is where the state has decided that a specific area is a priority, can we give the MCOs incentives and credit for doing work in that area? And one of the things that's been discussed, I think, a lot today is social determinants of health. And so if there's work being done by MCOs in social determinants of health, can we incorporate that into our alternative payment model framework so that we're just not focused on the targets alone? And so we're working on these changes over this year, and we look forward to sharing additional information and partnering with stakeholders over this, on this effort over the next year. I hope what's clear is that from unwinding the PHE to transitioning to value-based care, these efforts require engagement and partnership from the people we serve, the providers, the managed care organizations, and other program stakeholders. And I want to thank you for your work on behalf of the Texas Medicaid program, and particularly through the PHE. I hope it's ending sooner rather than later, and I know that so many of y'all have done so much work through the PHE. And we look forward to continuing to partner with you to continue to improve the Medicaid program.
So Stephanie, you mentioned social determinants and tying those to APMs. There's also potentially the opportunity to have in lieu of services that are in that space. Is that something that y'all have considered?
Yes, I think we are, within our framework for APMs, we will be looking at how we can, again, incentivize our partners, both managed care organizations and providers, to pursue APMs. And we also are looking more broadly, I think, at the in lieu of option, because it does provide states some flexibility.
Great. And so in terms of your additional priorities, what would you say are some of your personal priorities as Medicaid director, and maybe also the agency's priorities going into the legislative session?
Yes, the legislative session will be here sooner than I think. And we have, you may know, we've put out our budget request for the next biennium. And so it's a reflection of some of the agency's priorities. Of course, we always have to target what we include in the budget, but there's a number of areas I would highlight. I think I've heard today a lot about workforce challenges, and we certainly acknowledge the workforce challenges within the agency, but also among providers and our partners. And so we do have an item, some of our items are what we call placeholders, and so there's still work being done to decide the exact requests that we'll be making of the legislature, but we do have a couple of different ways in which we're looking at workforce. I would say one of them is directly with rates, which as the Medicaid director, we get a lot of feedback on rates. And so we have some placeholders which we'll further refine to address, critical provider rate issues. The other areas, and I think I talked about flexibilities during the public health emergency. We did other things besides just allowing teleservices. Of course, we made changes to certain policies we had in place. And so we are looking at, are there policies that we allowed that helped with workforce issues during the PHE, and seeing if we can continue those policies, and where they may have a cost associated with them, is that something that we would put forward to the legislature? So I'd say workforce is something that is reflected in our appropriations request. Another area is mental health. And I mentioned, the work we're doing around in lieu of services. In Medicaid, we are certainly working to fill out the mental health continuum where we can, but the agency at a broader level is looking kind of systematically within Medicaid, as well as within our partners in another part of the agency that do community mental health services, and looking at what services exist today. Are there areas that we need to supplement those services? And so we do have another placeholder for mental health services in our budget requests. And then the last thing I'll mention is just a focus on home and community-based services, or long-term services and supports. We've had in the past requests related to interest lists for different programs, and other ways that we can improve the long-term services and support. So we also have an item for that.
Great. And so during your prepared remarks, you talked some about the unwinding of the PHE and restarting redeterminations and doing all of that. What is the state doing to prepare for the new, all these new redeterminations that you're going to have to do?
So there's work being done at different levels within the agency. You may know that we have an area of the agency that does Medicaid eligibility, and then, of course, within my area of Medicaid, we oversee the delivery system. And so on my side, we're working with the managed care organizations in different ways to help them contact members and inform members. I think a couple of examples are we got a waiver from the federal government to use addresses from the managed care organizations, which sounds like a simple thing, but if we don't have current information on people, it can impact their eligibility. And so we're going to be working with the MCOs to make sure we have the most current contact information on the members. We're also, this has been in progress, but we're working on the option that the managed care organizations have to text members. So we think that's another way that the managed care organizations can help contact members in a way that may be more familiar to them. I mean, I don't look at my mail, but I do read text. So I think we see it as an option to maybe better reach people. And then there's a lot of work, and my partners in eligibility will say that we will meet with anyone in this state who wants to talk about the unwinding. Again, I think we recognize that we're not always the person who is face-to-face with the member, and so we want to make sure all of our partners can help members to have a successful eligibility redetermination. So there's a lot of outreach that's happening from eligibility and from Medicaid, and if any of you want to contact me about that, I'm happy to set up further discussions. And then there's also just efforts to shore up the eligibility workforce. I think just like private providers and businesses have had workforce challenges, the state has workforce challenges as well. And so there's a really focused effort on recruiting eligibility workers, maintaining eligibility workers, and then just how the work gets done and gets prioritized by the eligibility workers.
Great, thanks. And so regarding COVID more generally, what would you say are some of your biggest lessons learned, and are there any things that you would have done differently?
I'm sure there's things I would have done differently, but I think the biggest lesson learned is that we were able to be flexible. I think, I do get asked sometimes as state Medicaid director, why does it take so long to do something? And I think in COVID, we were able to sometimes do things faster. There were processes that we typically follow that we might have expedited. And so I think it showed us where there's potential opportunities to be more flexible than we have been in the past, both how we operate as the agency and also just how we interact with our stakeholders.
Great. And so thinking about your job as state Medicaid director, what would you say is one of the hardest things about your job and maybe one of the most rewarding?
Uh-oh. I think the hardest thing is just the scope of the job. I could have. It's always challenging in this environment to pick what do I talk about, because we cover so much of the healthcare system within Medicaid. And so I do as I said, I liked going to some of the panels and hearing just deep dives into certain areas, because there's a broad scope for the Medicaid program, which can be a challenge. And it can be particularly challenging, again, in how we engage with people and how we make sure that we're adequately communicating what's happening within the agency and why we're doing things. And so I think that's the biggest challenge for me. What was the second part?
Things that you particularly like about your job?
Oh.
What's most rewarding, maybe? You don't have to like it.
Well, I think it's important for people to know that, and this is true for everyone on my team, that we really do have a sense of service, and that's why we are doing this work. And so while, we can seem like a large agency that has a lot of process, we got into it because we really do want to do the right thing for the people we serve. And so that's the best part of the job for me, and seeing my team, who's really committed to that mission, carry it out every day.
Great. And so we just have a few more minutes left. I want to open it up again to the audience to see if y'all have any questions, if anyone has any questions that you'd like to ask before we wrap up.
Well, I have a closing question, so thank you again. Sure. So you've got a magic wand. What's one thing you would change with your magic wand? What's one thing you would change about the Texas Medicaid program or the healthcare system?
I think I want providers to love participating in Medicaid. So that's the thing I would change if I could change anything, mainly because that is how our members get served. And so I want our members to have the best access and the best quality of care that we can provide, and that often rests with the provider's experience of participating in the Medicaid program.
Great. Well, please join me in thanking Stephanie for being here today.